How are we? How are you all? It's been long since we
Good,
had a.
good, ma'am.
So just saying she's good. I could see some new faces, new names I could see. For all of you, I'm Sweetie. I'll be teaching you today about renal system and some of the renal medications. So as you all know, renal system is one of the most important or the frequently asked system in NCLEX. So that is next to cardiovascular system. And so we can expect few important questions from renal system. Okay, and renal system is something which is vast, and of course we cannot cover all the conditions in this 3 hours, but we'll try to we have included all the important topics or frequently asked areas of NCLEX in this session. Okay. Hope you all are preparing intensely for your NCLEX exam, and most of you, like some of you at least, must have got your dates for your exams, right? And so as I always tell you, this is a bit heavy, like it is not an easy thing that we are learning. So it is always to give a particular time period for yourself to attain to reach this goal. So suppose if you are preparing for this NCLEX for at least 3 months, so this 3 months you intensely or completely devote yourself for this NCLEX classes and NCLEX learning, and give your exams at the earliest, because carrying all this information of NCLEX in your brain is something very heavy. So if once you feel that you're ready for your exam, then give it. So as so what's a technique, how you yourself analyze or evaluate that you're ready for your NCLEX? So you will be randomly selecting 100 questions from 100 multiple choice questions you'll be selecting, and if you're able to clear at least 70 questions out of that, then you're almost ready for your test. Okay, so that's a time. And you have to also keep in mind that AFRA is giving ATT numbers. They're taking at least 6 weeks to 8 weeks to get an ATT number. So in advance, you have to plan your dates and the preparations for your test as well. Okay, so without wasting much of our time, we'll start with the session. I'll start. I'll share my screen. Is it visible?
Yes, ma'am.
Yeah. Yeah. Okay. So so we'll start with some of the diagnostic tests that NCLEX mainly focuses on. So the first thing is kidney biopsy. So we know that kidney biopsy, you may be working in an renal ward or a kidney in a theater. You may be knowing what is kidney biopsy procedure, or you must have learned in your graduate level, you must have learned what is kidney biopsy procedure. So so NCLEX is not worried about how they are doing or the doctor's part of that. NCLEX is more worried about the patient safety and our safety, nurse's safety, right? So which position you'll be preferably giving for kidney biopsy? That's one concern of NCLEX. So of course, before the procedure, we have to give which position for the patients before biopsy, before we take biopsy.
Prone position. Prone position.
Prone position, because our kidney is located anteriorly or posteriorly, where it is located?
Posteriorly.
Posteriorly. So definitely we are giving prone position for patients before kidney biopsy. So that's one concern of that's one area the NCLEX can focus on. And also the vasculature or the blood supply to the kidney is very high. It is next to liver. Liver has a very rich blood supply, so we can expect a very high bleeding, or there is a great chance of hemorrhage if we are this is something that is puncturing, or we are taking a tissue from the kidney, so there is a chance of bleeding. So it is very important to monitor the patient during the procedure and immediately after the procedure. And of course, which position you may be probably giving after the biopsy?
Supine position.
Which position?
Supine.
Not supine position. It is actually a
Sideline.
position where, sideline position, where this will compress the area from where we have taken the biopsy. So the position should be in such a way that it should compress the area from where we have taken the biopsy. Okay, so so before the procedure, the client must be informed. So definitely the informed consent, and the client has to discontinue all the anticoagulants. And not only anticoagulants, antiplatelet agents like aspirin, clopidogrel, anything which can lead to bleeding, that will be stopped at least 1 week prior. And though there is no much risk of bleeding, still we'll be making arrangements for blood transfusion. So we'll be checking the blood group, and cross matching of the blood should be done in case if there is severe bleeding, we have to go for a blood transfusion. Okay. And the blood pressure, if the blood pressure is very high, we should not go for this procedure. So all these things will be keeping in mind if you get a question from kidney biopsy, because so kidneys, vasculature, you have to keep in mind, and some of the these are very simple, and it is easy to remember as well. So this you'll be keeping in mind if you get a question from kidney biopsy. And after the procedure, the nurse should monitor vital signs at least every 15 minutes for the first 1 hour. Okay, so every 15 minutes, the nurse will be taking the blood pressure, the vital signs of the patient will be monitored by the nurse. And also if there is tachycardia, tachypnea, hypertension, so this indicates that there is a blood loss. If there is a blood loss, that means the blood is escaping somewhere, and the heart is not getting adequate blood. If heart is not getting adequate blood, it will try to pump more frequently. So that is tachycardia. So whenever there is any bleeding or any hemorrhage, then there will be tachycardia. Definitely the lung will try to take more oxygen, so that will come up as, or that will that can be elicited as tachypnea. And definitely there is blood loss, so there will be hypotension for the patient. So you have to always monitor the dressing site of the patient, because if there is profuse bleeding from the site, that we have to immediately report to the HCP. And the client should be positioned on the affected side for at least 30 to 60 minutes. And we have to make sure that the bleeding has almost stopped before we change the position of the patient. Okay, this is in brief about kidney biopsy. Okay, just to wake you up, a question. Who will read it for me? Lenny Mole?
Yes,
Lenny
ma'am.
Mole? Yeah.
Hi.
Can you read?
Yes. Yeah. The nurse cares for a patient scheduled for a percutaneous left kidney biopsy as an outpatient. Which intervention should be the nurse include in the client's post-procedure care plan? Option 1, compare pre and post-procedure BUN and creatinine levels. Second one, insert and maintain the patency of an indwelling urinary catheter. Third one, maintain prone position for at least 30 minutes. Fourth one, monitor vital signs for 50 minutes for the first hour. The answer is fourth one.
Fourth one, monitor vital signs every 15 minutes for the first 1 hour. Okay, so I just wanted to ask you why you didn't select the first option.
It will be
Any
same.
rationale? Yeah, there won't be much change. Before and after the procedure, there won't be much change in burn and creatinine. So we are not selecting that option. Second one. Second one, why you're not selecting the second one?
This patient is outpatient. Just
Yeah, it is. It is this procedure is mostly an outpatient or an OP procedure. It is conducted. Here it has mentioned as well. It is an outpatient procedure, and it is not mandatory. That there is no issue. They have not mentioned any issue with the outflow of urine. So there is no need of inserting an indwelling catheter. And what about the third option? Third
prone
option.
position.
Prone position.
Prone position, definitely we won't give prone position. This is after procedure. So you are selecting the fourth option. Okay. Now, next question. Pratiksha. Is she attending? Pratiksha? Yeah.
Yeah.
Can
The
you read
nurse
it for
is
me?
caring for the
Yeah.
nurse is caring for multiple clients who underwent renal system diagnostic testing, should report with post-procedure finding to the healthcare provider.
Yes.
150 ml residual urine on bladder scan, burning
Mhm.
sensation when voiding after cystoscopy, increased urinary output after arteriogram, less
Mhm.
than 10,000 organisms on urine culture.
Okay. So she's a busy nurse. She's carrying multiple clients who underwent, she's working in a department where the patients have undergone different procedures, and she has to decide which finding has to be reported to the healthcare provider. Okay, so which one she'll be selecting here?
Option 1.
Option 1, 150 ml residual urine on bladder scan. Why? Why is she selecting 1?
There is not supposed to be an residual urine
So
after voiding.
after voiding, there should not be any residual urine. Should not be there.
I think it should be less than 100 or around
Very
100.
good. Yeah, it is. That's a value. NCLEX has NCLEX is accepting a value of residual urine of 100 mils or less than that. So because of that, here it is high. It is 150 mil. But when you work in a medical unit, you probably will be doing a bladder scan, and if up to 150 is okay, but for NCLEX point of view, you have to keep in mind that it should be less than 100 mil. Okay, so since it is less than 100, since it is more than 150, since it is 150 mil here, so you have to inform that to the healthcare provider. What about the second option, burning sensation when voiding after cystoscopy?
Expected.
It is expected.
It is expected because a cystoscope is inserted through the urethra to visualize your bladder. So it's a painful procedure. So a bit of burning sensation after the procedure for 1 or 2 days, it is an expected thing. So we are not selecting that option. Third option. What is arteriogram? Increased urinary output after arteriogram. So this is a procedure where a contrast dye is injected into the femoral artery to visualize the blood supply to the kidney. So if there is any issue with the kidney, if there is any stenosis or if there is any thrombosis present in the artery, that can be identified by this particular procedure. So we are injecting a contrast dye. So whenever we are injecting contrast dye, we'll always teach the patient to drink a lot of water. So because of that, definitely the urine output after the procedure will be very high. So this is also an expected thing. So we are not selecting second and third. Last one. Last one, less than 10,000 organisms per mil on urine culture. 10,000. Why you're not selecting the fourth option?
More than 10,000 is a problem. Less than 10,000.
Yes. Yeah, urine is a sterile fluid, but the urethra will have some amount of organisms. But in culture, if it is up to 10,000, it is normal. But if it is beyond that, then it is considered as abnormal, or there is a sign of infection. So we are selecting the first option. Okay, next one. So quickly about acute pyelonephritis. So you may be knowing, must have learned about urinary tract infection, right? What is urinary tract infection? Anyone? Urinary tract infection, where it is mainly, which part of the urinary system it is mainly affecting?
Urethra, kidney, and bladder.
Is it affecting urethra, kidney, and bladder? Urinary tract infection? Not really. It is mainly affecting the urethra. It is mainly affecting the urethra. And cystitis, have you heard about the cystitis?
Infection of bladder.
Yes.
Yeah, infection of the bladder. So in the urinary tract infection, it is just the urethra. It is not reaching up to the bladder. Whereas in cystitis, it is mainly affecting the bladder. And in acute pyelonephritis, it is mainly affecting the kidney. Okay, so the cause can be an ascending urinary tract infection. So in acute pyelonephritis, the symptoms may be the same, almost the same symptoms we can see in acute pyelonephritis and urinary tract infection. Okay, so as per the definition, acute pyelonephritis is an infection of the kidney. It is usually by the extension from the lower urinary tract. So if you're not treating your urinary tract infection, it can ascend and it can affect the upper parts of the urinary system, that is bladder and kidney. Mainly clinical features. So I think almost all must have taken care of a patient with urinary tract infection, or you yourself must have suffered at least once in your life with this urinary tract infection, and you know that the fever, chills, and you'll feel like vomiting, you'll be always nauseated. And typically for acute pyelonephritis, the patients will complain there will be a dull pain, dull pain in the flank region. Okay, especially in the costovertebral region. Jacob, can you mute your mic? Okay, thank you. It is in the costovertebral region. What is a costovertebral region? Where your vertebra and ribs join. There is that particular region. If the patient is having a dull pain, and if that pain is radiating to the umbilicus, so that is a typical feature of acute pyelonephritis. So, and there will be tenderness. So what's the difference between a pain and tenderness? What's the difference? Pain and tenderness? What's the difference? Pain and tenderness? Anyone?
Pain is always there.
Okay.
Tenderness when you touch.
Okay, so it is that tenderness is that pain when you touch a particular area, right? Okay, very good. The answer is correct. So so there will be tenderness in the costovertebral area, and there will be flank pain, and that will be a kind of dull pain. If it is a sharp pain, what it can be? If it is a very sharp or shrewd pain in the flank region, if the patient is complaining, what it can be? It is also related to renal system.
Kidney stone.
It can be a kidney stone. Kidney stone is very sharp pain, whereas a dull flank pain indicates acute pyelonephritis. Okay, so management, as we all know that it's an infection. So infection, how we are treating. So we have a practice that whenever we get any infection, we go to a doctor, and the doctor will prescribe some antibiotic, and we'll be fine. But as per NCLEX, it should be always, it should be a culture and sensitivity test. Then that has to be followed by antibiotic. Okay, so that you will be keeping in mind. So always send the samples for blood and urine culture should be obtained prior to initiating antibiotic therapy. Whenever possible, identify the exact causative organism, then start with the antibiotic. So this you will be keeping in mind in case of any infection or anything. If there is an option of blood culture and antibiotic, definitely you will choose blood culture first, followed by antibiotic. Okay. Easy question. Who wants to read? Navdeep?
Yes, ma'am. The nurse is caring for a 72-year-old client with a history of renal calculi and diabetes mellitus who has admitted for acute pyelonephritis. The nurse assesses shaking chills, temperature of 100.2 degree Fahrenheit, and flank pain. Which of the following is the priority nursing intervention? Number 1 is administer intravenous antibiotics. Second, check baseline serum creatinine level. Third, have the client strain all urine. And fourth is obtain blood and urine cultures.
What will be the answer?
Obtain blood and urine culture.
Okay, so obtain
Number
blood and
4.
urine culture is the option. Option 4, you're going with option 4, right? Okay, so there is a tricky option they have given. Have the client strain all urine. Why they have given that option? Have the client strain all urine.
Check the renal stone.
Yeah, because the patient is having renal calculi, they have mentioned in the question, but that's a history. But at present, the patient is presenting with all the symptoms of an infection. So our focus should be on controlling the infection. So definitely before any antibiotic, we're selecting blood and urine culture. Okay, moving on. Next question. We'll read it. Danya?
Yes, ma'am. Client with
Can you-
signs and symptoms of UTI collected a Muslim urine specimen 2 hours prior and left it sitting in the bathroom. What is the nurse priority action? Option: first one, send specimen immediately to lab, discard the specimen and obtain new. Confirm which client that it is midstream urine, keep in refrigerator and send it to lab when needed.
Yes.
Second one, discard the specimen.
Option 2.
Discard the specimen and obtain new, right? Okay, so if immediately after collecting the urine, if the lab is not free, at the earliest we have to send it to the lab. If not, we have to keep it in the
Refrigerator.
refrigerator. So here the specimen was found 2 hours prior and it was left sitting in the bathroom, so we cannot use that particular specimen. So it's easy. Okay, next one, benign prostatic hyperplasia. Benign prostatic hyperplasia. So it is a big mass of something, a big mass of prostate, which is pressing the urethra of male, and this is obstructing the urine outflow from the bladder. So what will happen in the bladder? The urine will be collected in the bladder, and the patients will have how the patient will be voiding. What will be the pattern of voiding? The stream of voiding. There will be dribbling. So the patient cannot void easily. As normal, the patient cannot void. So there will be dribbling. What else the patients will be having? Dribbling. Whether the patient will be feeling like, yes, I have completely voided. Whether that feeling will be there for the patient?
No.
No, always there will be residual urine present in the bladder, and always the patients will have the feeling of incomplete voiding. Okay, what else? The signs and symptoms, always there will be urinary retention, sensation of incomplete emptying, increased urgency to void, and straining or difficulty in initiating voiding, or it is known as hesitancy. There will be some strain, like always straining, because the big mass of prostate is obstructing the urethra. So the patient has to always strain for starting or initiating the voiding. There will be weak or intermittent stream of urine during voiding. It won't be the normal flow because it has to pass through that constructed part of the urethra. So definitely there will be a weak or intermittent stream. Frequent voiding pattern throughout the day, because always the patient is having the feeling that he has not passed the urine completely. So always like urinating, more frequency of urination. We can, especially nighttime, the patients will be having a more frequently the patient's sleep will be disturbed because of the incomplete voiding sensation. Okay, so these are the signs and symptoms of benign prostatic hyperplasia. Okay, a question. Who will read it? Somebody volunteering for reading this? Samriddhi, can you read? Samriddhi, is she attending?
I'll go.
Okay. Rabina.
A client who was discharged following a prostatectomy performed 6 days ago calls the clinic and reports passing some small blood clots and experiencing a decreased urinary stream. What is the nurse's best response? First, please come to the clinic to be evaluated by the healthcare provider. Second, those symptoms are normal in the first week following surgery. 3, try to bear down if having a bowel movement. And the last one, you should increase your daily fluid intake.
Okay. What could be the answer? So who's going with the option 2? Is it Frankie? Frankie said those symptoms are normal in the first week following surgery. Anybody has a different option? Like anybody selecting a different option?
4.
You should increase your daily fluid intake. 4. Any other option?
First one.
1.
Option 1. Ravina is going with option 1. Any other option? No other option. Okay, so we'll see one by one. Please come to the clinic to be evaluated by the healthcare provider. So here the client had a benign prostatic hyperplasia, had a big prostate, and he was having some difficulty in passing urine. Definitely for that reason, he must have undergone this prostatectomy, so removal of the prostate. This has performed 6 days ago, and he calls the clinic and reports passing small blood clots and experiencing a decreased urinary outflow. So if he has undergone the surgery, he will make sure that he is passing urine at the normal rate. He found that there is something wrong. There is decreased urinary outflow and than the normal one, because since these 6 days he was passing urine normally, and he suddenly noticed that there is some issue with my urinary outflow, and he has also noticed that there is some blood clots. Okay, so if somebody is calling you, definitely that means there is something wrong with the patient, because there is an obstruction, because the prostate, the removed prostate or some blood clot, something has obstructed the urethra. So definitely the first option, that means here to immediately come to the clinic and the doctor has to evaluate you. Definitely the patients will be given instructions to drink plenty of water immediately after the surgery. So it just increasing a daily fluid intake has nothing to do with that. And try to bear down. Already the patient, if it is when he was having this prostatic hyperplasia, he was doing that bearing down. Now that issue is resolved and he has to pass urine as a normal person, or if there is some issue, there is the bearing down is not the option that a nurse can suggest in this post surgery time. And also these symptoms are not normal, because the patient himself has found there is something abnormal. So the only option we can select is first one: please come to the clinic to be evaluated by a healthcare provider. Is the rationale clear?
Yes.
Okay. Next question. Who will read it? Lakshmi? Lakshmi is
Yes, ma'am.
attending?
Yes. The nurse assesses a client with benign prostatic hyperplasia. Which client statement requires further assessment? First option, I have a burning sensation when I urinate. Second, I have been having some dribbling after I finish urinating. Third, I missed 3 days of finasteride while on a trip last week. Fourth one, I was awakened 3 times last night by the need to urinate.
Yeah. So the nurse assesses a client with BPH, a big prostrate, okay, which is obstructing the urinary outflow. Some statement by the patient is not need further assessment. Okay. Something is not expected, need further assessment from a patient with benign prostatic hyperplasia, something unexpected, or not, it is not expected finding of BPH. What could be that?
Third one, ma'am.
By the way, what is finasteride? Anybody has any idea what is finasteride?
Ma'am, it's medication for
Yeah,
the BPH.
very good. It's a finasteride is a drug which we'll be giving for shrinking the big prostrate or enlarged prostrate. But if the patient is missing that dose for just 3 days, it's a long-acting medication. So it has nothing to do with 3 days. So that option we are canceling. We are not selecting that option because it is a long-acting medication. Okay. Now, what about the other 3? 1, 2, 4
One.
option? 1, I have a burning sensation when I urinate. Okay. Whether this is expected of a benign prostatic hyperplasia.
No.
I have burning sensation when I urinate.
No, burning sensation will not be there.
Yeah, which condition is associated with burning sensation? Just now we learned that.
UTI,
It is
pyelonephritis.
pyelonephritis and UTI, because the patient is not voiding properly. There is residual urine present in the bladder. The patient must have developed a urinary tract infection. So that's a statement by the patient. I have a burning sensation when I urinate. So this particular statement need further assessment. Okay, so we are selecting the first option. What about the second option?
It is expected in.
It is
BPH.
expected. Okay, it is expected. So we are not selecting. What was the last one? What is the last one?
It's also expected.
It is also expected sign of benign prostatic hyperplasia. Okay, next question. We'll read it. Monica? Monica,
Yes, ma'am.
can you read it?
Okay. The nurse gathers a health history from a 58-year-old male client with acute urinary retention. Which of the following questions should the nurse ask to aid in assessing for benign prostatic hyperplasia? Select all that apply. Do you feel the need to urinate again immediately after urinating? Option 2, do you have to strain to begin your stream of urine? How often do you engage in sexual intercourse? How often do you wake at night with the urge to urinate? Is your stream of urine weak or intermittent?
Yeah, this is a select all that apply question. So you'll be selecting whatever possible options.
Stream.
1, 4, and 5.
1, 4, and 5. Okay, so the first option you selected is, do you feel the need to urinate again immediately after urination? So that's an expected sign and symptom of clinical feature of BPH, right? So that question you can ask. What about the second option? No, you're not selecting the second option, right? 1, 4, and 5, right?
4 and 5.
Okay, fourth option, how often do you wake at night with the urge to urinate? Definitely the patients with BPH, they'll be frequently getting up because they have the urge to urinate. Okay, fifth option, is your stream of urine weak or intermittent, right? Monica? Is your stream of urine weak or intermittent? Okay, of course, it is an expected expected thing, because there will be a weak stream of urine or intermittent urination because of the big prostate. Okay, what about why you didn't select second and third option?
Because we don't have to strain to begin the urine. There is dribbling.
When we discussed about BPH, you remember the patients usually strain to start the stream of urination because there is a big mass of prostate that is obstructing their urethra. So they have to strain a bit to start the urination. Okay, it is not always dribbling. So there will be dribbling, but to initiate, some patients may have to strain a bit to initiate urination. Okay, so this is also expected. Okay, so option 1, 2, 4, and 5 is expected. What about the third option?
Not relevant.
Not related to BPH or anything. So we will not get any data from this question. So it's an irrelevant question. So we are not selecting option 3. I think I can select 1, 2, 4, and 5. Let me check. Yes. How do you feel? Do you feel the need to? Yeah. So these are the 4 options I'm selecting in select all that apply question. So, so you all are aware that in select all that apply question, sometimes only one option may be correct. Sometimes all the 5 options may be correct. But if you're missing any one option from that, you will miss the entire mark for that particular, entire mark for that particular question. So it is very important to go through each option carefully and select it. Quickly into renal calculi. Renal calculi, as we all know that it's a painful thing that a patient must be experiencing. This is the most painful, one of the most painful. It is almost like studies have compared this pain with the labor pain, or it is even worse than labor pain. So what are the risk factors for developing renal calculi? We know that renal calculi runs in families, and some of the dietary pattern, especially if the patient is dehydrated, yeah, and high calcium intake, presence of oxalates, like some patients, they have like a complaint that those who are eating yam, elephant food, you must be knowing that yam, this is an underground vegetable that will increase calcium oxalate level in your body, and that can lead to renal calculi. So family history, dietary imbalance, immobilization, especially those who are bedridden or those who have undergone surgeries, they are immobile, and there is a huge risk that it can develop renal calculi. And dehydration is a big cause of renal calculi as well. Clinical manifestations, we all know that it is a sudden severe abdominal pain or flank pain, and it is associated with nausea and vomiting. Management will be giving analgesics or Schedule 8 medications. the most powerful painkillers may be effective, not with paracetamol and other stuff. They won't be getting any relief with simple analgesics. So, but at regular intervals, they have to take this Schedule 8 drugs to get some control over this particular pain. And rehydration up to 3 liters per day. They'll be drinking plenty of water. So this will help in the movement of the calculi from the area where it is located towards the bladder, and it will help to escape the calculi through urine. Ambulation to facilitate the passage of calculi. So always these points you'll be keeping in mind if you get a question from renal calculi. Management, there are different ways of managing. There are the patients will try, if these are very small stones or calculi, they will be given some dietary modifications. So it is very important to collect all the stone, whatever they are passing through their urine, to determine what type of stone they are having in their body. Okay, so so it is very important to strain the urine of a patient with the renal calculi, and this will help. The type of stone present in the body will help the dietitian and the physician to help them prescribing the medication and also giving some dietary modifications. So it's our responsibility to inform the patient that whatever urine they are passing, they have to strain it, and they have to save the stones, whatever they got it after the straining of urine. Okay, and another non-invasive technique is extracorporeal shockwave lithotripsy. This we are performing in OT. So we know that this particular procedure will be breaking down all the bigger stones which is present in the kidney, and if the fragments of those stones will be escaped through urine, and the patient will be patient will be relieved of this renal calculi. And it is known as ESWL, that is extracorporeal shockwave lithotripsy. It's a non-invasive procedure. The procedure is done under general anesthesia, and some amount of bruising after this procedure is an expected thing. So where attaching the machine, I'm not sure about the reason, but as NCLEX point of view, we'll be keeping in mind some amount of bruising on the flank region is an expected finding of this particular procedure. If there is bleeding from that area, if there is any bleeding, or if there is any fever or chills the patient is developing, that is an unexpected finding of extracorporeal shockwave lithotripsy. Bruising is expected. Okay. Okay, and to remove any obstruction by the fragments of stone or fragments of calculi, they'll be placing a stent in the ureter, and this will help to remove the without any obstruction. This will keep the stent will keep the ureter open and dilated, so without any obstruction, the stones can be the fragments of stones can be escaped through urine. Okay, so when we are sending the patient for ESWL procedure, some of the points we'll be keeping in mind are patient teaching. Patient teaching is something NCLEX is very keen to. We are supposed to teach the patient before any procedure. So these are very simple. Increase the fluid intake to flush the fragments of stone out of kidney. Expect some bruising and pain on the back or on the affected area. Analgesics may be required for some patients. Expect to see blood in the urine because the fragments are passing through the urethra. It can create a minute injury to the urethra, and some amount of blood is expected after ESWL. Urine color should progress from bright red to pink tinged. So immediately after the procedure, the urine will be bright red, and as the days progresses, it will turn into pink. By second or third day, it will be pink, and it will become a normal color within 3 days. Hematuria is concerning if the urine remains bright red for a prolonged period of time. So that means, so initially it will be bright red, and later on, as the as the time progresses, it will turn into pink, and later on it will become straw in color. I mean that normal urine color it will become. But if there is prolonged bleeding or prolonged bright red color for more than 24 hours, this is something which has to be reported immediately. Report any signs and symptoms of infection, because so as I told you, some bruising is expected, some pain is expected within 24 hours. But if there is fever and chills, that means there is an infection. So that has to be reported immediately. And also if the urine color is bright red within even after 24 hours, that has to be reported. Okay. Question answer. Gurpreet. I don't know whether I'm pronouncing it right. It's Gurpreet, right? Is she attending? No. Richa?
Yes, ma'am. The nurse is caring for a client with multiple renal calculi. Which nursing interventions should be included in the plan of care? SETA. Number 1, administer analgesics at regularly scheduled intervals. Second, encourage fluid intake of up to 3 liters a day. Number 3, instruct client to stay on bed rest. Number 4, provide massage to the client's flank. Number 5, strain all the urine for the presence of stones.
I think you'll score full mark for this SATA question.
1, 2, 5.
1, 2, and 5. Yes. So the first one is administer analgesics. Definitely we have to give because it is renal calculi. Second one, encourage fluid intake up to 3 liters. Definitely plenty of water. Third one, instruct the client to stay on bed rest. Whether you'll do that, whether you will be doing that.
No, we have to ambulate the client.
Yeah, ambulation is very important. Fourth one, provide massage the client's flank region. Will never do that. Massaging. And fifth one is strain all the urine for the presence of stone. That's important to determine the type of stone. Okay. Yes, we're right. Next question. Who will read it? Gibbons. Gibbons. Are you attending? No. Jacob.
Yes, ma'am.
Can you read it?
Nurse is caring for a client who received extracorporeal shockwave lithotripsy with urethral stent placement for treatment of a kidney stone. Which discharge instructions provided by the nurse are appropriate? Select all that apply. Contact your healthcare provider if you develop fever or chills. 2, except for using the bathroom, you should stay in bed rest for the next 48 hours. 3, increase your fluid intake to help flush out the kidney stone fragments. 4, it is common to have some blood in the urine up to 24 hours after this procedure. 5, you may develop some bruising on your back or on the side of your abdomen.
So the nurse is providing some instructions for a patient who had who received ESWL. Okay, so these are the discharge instructions by the nurse. Okay, so what are appropriate?
1, 3, 4, 5.
1, 3, 4, and 5. First one, contact your healthcare provider if you develop fever and chills. What it indicates?
Infection.
Fever and chills.
Infection.
Signs of infection.
So we have to inform. So that's right. The nurse is right here. Second one.
No.
Second one. Second option. Jacob, are you selecting the second option?
No, you should ambulate.
Ambulation. So it is against ambulation or ambulation policy. So we're not selecting that. Third one.
Yeah.
Yes. Fourth one.
Yeah, it's right.
It is common after 24 hours.
It is common, right? It is common. Yeah, I think I'll select that. Okay. One. I'm selecting 3. I'm selecting 4. I'm selecting fifth one?
So 5, yeah, bruising on the
Yeah, it's
part.
some bruising is expected. Okay, let me check the answer. Yes, right. I was confused about the fourth one. Yeah. Next one, acute renal failure. Acute renal failure. So as we all know that a kidney is just like our filters, right? So they are filtering all the blood and whatever has to be excreted, that they are excreting. And if there is anything wrong with the filter, the entire fluid will be accumulated along with the waste products in the body, right? So the causes of acute renal failure can be pre-renal causes, intrarenal causes, and post-renal causes. It depends upon the area. Somebody is not on mute. Okay, who's that? Okay, so pre-renal causes. So we know that heart as an organ is a main organ which is supplying all the blood to the different organs, and there is a rich blood supply to the kidneys. So if there is anything which cause reduced blood supply to the kidney, can affect the normal functioning of our kidney, and finally leads to acute renal failure. So if anything, so the causes, when the name itself, it is pre-renal, so it is not related to renal, it is something above renal. So it is basically some other system other than kidney. If there is any issue and that is obstructing blood flow to the kidney, can be a pre-renal cause. Okay, so it is mainly the cardiac causes. So if the patient is having a myocardial infarction, or if the patient is having any other cardiac issues where the heart cannot pump adequate blood to the kidney, then the patient, the kidney won't be getting adequate blood, and the filters may not be working properly. Definitely it is affecting the normal functioning of our renal system. And dehydration, in case of dehydration, the heart is not able to pump adequate amount of blood volume to the kidney, so that can be a cause of that can be a pre-renal cause of acute renal failure. So you may be thinking that whether dehydration, how a person can be that dehydrated. So there are soldiers, or there are people, those who are working in the mine, and so such Sophie, I think you are using a chalk or something. Are you using a pen to? She's yeah. Please stop writing on the board. Yeah, dehydration. So that can be a cause of pre-renal cause of. Though if you're not drinking water for a prolonged for at least 1 week, they may be carrying only one bottle. Some of the soldiers, those who are on the borders, those who are those who are preparing for war, or those who are attending the war field, they may be getting very less water, and that later on that can lead to acute renal failure. Okay, there were patients, they were actually soldiers, and they had developed dehydration related renal failure, and that had led to the death of such patients. And burns, definitely there is fluid shift, and we know that there will be fluid shift into the intravascular space, and there won't be much fluid in the normal circulation, and blood, the heart cannot pump adequate blood to the kidney, so that leads to acute renal failure. And decreased renal flow, so that can be a renal calculi. So if there is a calculi that is obstructing or that obstruct the blood flow to the other parts of the kidney, that leads to acute renal failure. Hypotension, just like dehydration, there is no much pumping. If the patient is in a hypotensive condition, the adequate pressure to pump the blood to the kidney is not present, so definitely the patients develop acute renal failure. Okay, now moving on to the intrarenal causes. Intrarenal causes, like that is something wrong with the kidney, and kidney is having something called nephrons, that is mainly the functional units of kidney, where the main filtration is happening. Okay, so if there is any inflammation of the nephrons, it is called as nephritis. So so it is mainly the problem with the kidney. And also we know that autoimmune diseases like systemic lupus erythematosus, our own body is producing antibodies against it. So in such cases, there is a chance that this big molecules can accumulate in the nephrons and can cause the death or deterioration in the renal functioning. CT contrast, of course, always we have to keep CT contrast. Those patients who are receiving CT contrast, they have to drink plenty of water, and they have to make sure that they are eliminating all the CT contrast from their body. And we'll also keep in mind that if the patient is having any renal or any liver issues, we should not administer CT contrast. Okay, so contrast is very thick. So this is like a cement that we are putting on the nephrons, and we are pouring water. Because of the cement-like material, this contrast is very thick, and this will kill the nephrons and the filtration capacity of the entire kidney. Antibiotics, especially we have already learned when we learned about antibiotics, vancomycin and gentamicin, that's a sin. So you must have seen some videos, YouTube videos, they'll mainly focus on NCLEX videos, they mainly focus on that's a sin. If those antibiotics ending with sin, so that is vancomycin and gentamicin, so those category of antibiotics are very dangerous, and that will deteriorate the renal function of a patient. So this will be a last option whenever we are administering, because if the patient is having any renal impairment, slight renal impairment, that will decline the renal functioning of the patient. And long-term use of NSAIDs. NSAIDs are dangerous, that we all know. Next to antibiotic, we all have that fear that whenever we take NSAIDs, we have the fear that it can cause renal and hepatic failure. So these are potential. These have the capacity to kill our hepatic cells and nephrons. So NSAIDs and antibiotics will be, of course, vancomycin and gentamicin. Then these are very dangerous to the kidney. What about floxacin? Floxacin, you must have heard, right? Floxacin, levofloxacin and stuff like that.
Yeah.
Have you heard about such so that is also ending with sin, right? Floxacin, levofloxacin. Whether that is dangerous to the kidney? Levofloxacin. I told all the sin. The drugs ending with sin is a sin to the kidney. So if you're giving, that's a sin that we are doing to the kidney. So whether levofloxacin is a sin? Not really. It is mainly vancomycin and gentamicin, because that's a different category of antibiotic, and it is the most commonly used antibiotic for urinary tract infections, levofloxacin. Okay, so only vancomycin and gentamicin you will be keeping in mind, that you will not be administering if the patient is having any renal issues. Okay, and some of the post-renal causes. So we said pre-renal causes, that is above kidney, and intrarenal causes, that is within the kidney. There is some issue with the kidney, especially with the nephrons. So that's intrarenal causes. And post-renal, that means after a kidney, that means it can be a prostrate. So we know that it is below kidney. It can be a urinary retention. If there is benign prostatic hyperplasia, what happens? Usually the urine will be collected in the bladder, and there is a chance that there will be upward flow of this urine into the kidney, and that can damage the nephrons. Okay, so in BPH, urinary retention, and any tumor of the urinary tract, what happens? There will be urinary retention, and that there will be backflow of urine into the kidney, and that can destroy the nephrons and ultimately the entire functioning of kidney. So these are the main causes of acute renal failure. So based on the area which is affected, the questions may vary in NCLEX. So that's why I just explained you this causes. And about if the patient is having any renal failure. Some of the electrolyte or some of the lab values that we have to keep in mind in case of renal system, that we all know that it is creatine, right? Creatine, what's the normal value of creatine? Normal value of creatine?
0.6 to 1.2.
0.6 to 1.2. So if it is 1.3 milligram per deciliter, that means it is above the normal level. So and you have to also keep in mind that it is a waste product of muscle breakdown, and creatine is the only indicator that is not it is the only indicator that indicates the functioning of kidney. And because other factors, sometimes other organs or there is a chance that electrolytes are reabsorbed by kidney, or like sodium and potassium and other stuff. They may vary because there will be some reuptake of all those items. But whereas creatine, it is purely eliminated. It is something which is completely eliminated by kidney, and this is one of the best indicator of your kidney functioning. Okay, and what is blood urea nitrogen? What's the normal value of blood urea nitrogen?
10 to 25.
Up to 20 is normal. If it is above 20, if the Bund value is above 20, then it is abnormal. That means your kidneys are not functioning properly. And urine output, what's the normal urine output in a day?
1500 ml per day.
1500.
1500 ml or 30, if it is less than 30 mils per hour, or if it is less than 400 ml, what it indicates? If it is less than 400 mils per day, oliguria. That means your kidneys are not at all functioning properly, or you are completely dehydrated. There is something wrong. Okay, and pH should be always an acidic pH of less than 7.35. Okay, stages of renal failure. Acute renal failure. That is, the first stage is stage of initiation. So this stage is the beginning stage. So that means if there is any cardiac problem, or if there is an SLE, the course has already started, and it has started affecting your kidney, and there will be some signs and symptoms of kidney failure. That's a beginning stage. If you identify that at this stage, that's a best stage, because all this acute renal failure, something good about this is it is reversible. Kidney can come back to its normal functioning if you are giving treatment at a proper time. So few hours to few days it will last, and there'll be this is the initiation stage, is a stage where signs and symptoms will appear. Okay, the next stage, if you're not treating at this stage, the patient will go to a stage of oliguria. So as we all know that oliguria means less than 400 mils of urine per day, and the specific gravity, because it will be a thick dark urine, there will be high specific gravity for the urine, and there will be creatine level and urea level will be very high. And GFR, glomerular filtration rate. What is GFR? What's GFR? Glomerular filtration rate. What's that? It's 90 mils per minute.
Filtrate the blood.
Yeah, very good. It's the amount of blood filtered in a minute by the kidney. So, okay, that's glomerular filtration rate. It is almost 90 mils. If it is normally functioning kidney, it is 90 mils per minute. If it is less than that, that means the kidney is not filtering, or kidney is not filtering the blood properly. So this is oligouric phase. That means the urine is not passed properly. So whatever fluid is in the body is getting accumulated in the body. So there is a chance that there will be fluid overload, and that can lead to heart failure, and even the potassium is not excreted out, so there will be hyperkalemia and hyperphosphatemia. Okay, so hyperkalemia, hyperphosphatemia, and there will be increase in everything except the urine output and glomerular filtration rate. Okay. And if the patient is not getting any treatment, the treatment option at this stage is dialysis. But the dialysis we can start if the kidney is recovering, then we can stop. Like if you are identifying the cause of acute renal failure, and if we are treating that, we can stop dialysis and the kidney will start functioning normally. But if the patient is not getting any treatment, if the patient is not responding to treatment at this phase, then we go to okay, one more before that. So we know that if the patient is having oliguria at this stage, that means less than 400 mils of urine. What are nursing interventions what we can give at this phase? If you're getting a question that the patient is in this phase of acute renal failure, what are your interventions? So definitely it is oligouric phase. So you have to keep in mind all the lab values you'll be keeping in mind, and then the patient must be given a low protein diet. Why it is a low protein diet? Why the patient has to be given a low protein diet at this stage?
Means
Any
low
idea?
protein diet.
Low
For
protein
uric
diet.
acid. To control uric acid.
Very good. It's the breakdown of protein can lead to further increase in the amount of urea and uric acid. So to reduce that, we have to always tell the patient to take a low protein diet and restrict potassium rich food. Why?
Hyperkalemia.
Patient is having hyperkalemia, and the patient's kidneys are not filtering phosphate and potassium. So definitely we have to restrict the potassium rich food. And ECG monitoring is very important. Why? ECG monitoring is very important.
Hyperkalemia.
It is the potassium. Potassium is a villain here. And if there is increased level of potassium, that can lead to taller T waves, wide QRS complex, and prolonged PR interval. All those stuff you must have learned in your ECG interpretation classes. So ECG monitoring is very important if the patient is in this particular stage. And we may be giving K-Exhalate to the patient. What is a K-Exhalate?
It's antidote of hyperkalemia.
Hyperkalemia. So we know that it's a chemical symbol which we use for potassium is K, and K-Exhalate is a drug. So it helps the potassium to escape or exit from the body. So K-Exhalate is a drug which will be commonly in orally or in form of enema. We'll be giving K-Exhalate to get rid of the excess potassium. Okay, but it will take some days to act if the heart, or if there is arrhythmias, or if there is any issues. We have to we'll be discussing that how we are gonna manage those issues. Limit fluid intake. Why are limiting fluid intake? Already the patient is in an oligouric phase, right? Why they are limiting?
Volume overload.
Fluid volume overload.
Overload.
The kidney cannot filter the fluid, and it is accumulated in the body. So we are reducing, or we are limiting the fluid intake. IO chart, intake output chart, daily weight check of the patient is very important. Blood pressure monitoring is very important because there is a fluid overload for the patient. And we have to monitor the saturation level, because there is a chance that there is cardiac failure, and because of fluid overload there will be pulmonary edema, and this way so it is very important to check whether the patient is having any crackles or the saturation level of the patient. We have to monitor at this phase of oliguria. Okay, so you'll be keeping this points in mind when you get a question. Okay, and it will last for almost 1 to 2 weeks. And the patient will be also having pH, it will be an acidic condition, pH less than 7.35, and the patient will be confused because all this because of this presence of urea, creatinine, and all the metabolic waste product is accumulated in the body, and this can at least reach the brain, and the patient will be in a confused stage at in oligouric phase of acute renal failure. Okay. Next is the diuretic phase. Some patients may skip the oligouric phase and may go directly to the diuretic phase. Okay, so in such cases, but most of the patients, they will be initiation phase, oligouric phase, then goes to the diuretic phase. So here the kidney is gradually start functioning normally, but there is a lot of waste product which is accumulated in the body. There is a lot of fluid, there is a lot of waste products. So the kidney has to work hard in this phase. Okay, so there will be a pumping, there will be a urine output of 3 to 6 liters at this stage. So that's why we call it as a diuretic phase of renal failure. Okay, so what happens ultimately, the patient will be passing so much of urine, and some extent the patient will go to a stage of hypovolemia, dehydration, and hypotension, because there is so much fluid loss. And the opposite of oligouric phase, that means hypokalemia, will be happening in this phase of acute renal failure. So main nursing intervention is IV fluid. Though it is acute renal failure, we'll be still giving IV fluids because the patient is in a state of hypotension and hypovolemia. And strict IO chart should be maintained for this patient. But the interesting part of this phase is that the patient will be oriented, will be getting a bit better. The confusion and the other mental issues will be resolved in this diuretic phase of the acute kidney failure. If the patient is getting proper treatment, and if the cause of the acute renal failure is resolved or managed properly, then the patient will be having a normal functioning. So that's a recovery stage. So the patient will be coming back to normal. But there are cases, the acute renal failure can lead to chronic renal failure, and they'll be continuing with dialysis and other management. Okay. Okay, just to wake you up, another question. Navjot?
Yes, ma'am.
Can you read
A
it?
36 years, yes, ma'am. A 36 years old male patient is diagnosed with acute kidney injury. The patient's 24-hour urine output is 4.5 liters. Based on this stage of AKI, what complications and assessment findings may present in this patient's SATA? Water intoxications, hypotension, low urine specific gravity, hypokalemia, confusion due to azotemia.
Okay. So he is a 36-year-old male patient diagnosed with acute renal failure or acute kidney injury, and the 24-hour urine output is 4.5 liters. Okay, and this, what are what complications and assessments may be present in this patient? Select all that apply question. So which stage of renal failure the patient is in?
Diuretic.
Diuretic phase.
Diuretic phase. Okay, so diuretic phase, we know that if it is a diuretic phase, the patient will be passing 3 to 5 liters of urine. Then there will be hypovolemia, hypotension. Everything is low, right? Everything is low in this patient, but there won't be much confusion for the patient. Okay, so based on all that concepts in mind, you are looking into the options. First one, water intoxication.
No.
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 So in which stage it will be? Water intoxication will be present in which stage?
Oliguria.
Oliguria. Okay, oliguric phase of acute renal failure. So the first option, water intoxication, we are not selecting. Second option?
Yes, hypertension.
Yes.
Yes, hypotension. Okay. Third one?
Yes.
Low urine
Yes.
specific gravity. Yes. Okay. Fourth one?
Yes, hypokalemia is present.
Yeah, because in oliguric phase, there was hyperkalemia, but in diuretic phase, there will be hypokalemia. So I'm okay with second, third, and fourth option. Fifth one?
No, it's on oligouric phase.
It is in the oligouric phase, mainly the confusion patients will be having. Okay, so you're going with the option 2, 3, and 4, right? Okay, right. Next one. Chronic kidney disease or chronic renal failure. Okay, so how we diagnose a patient as a case of chronic renal disease and different stages it is based on the level of, it's based on their GFR value. Okay, so what's the normal GFR rate? Glomerular filtration rate?
More than 90
It's 125.
If it is more than 90 mils per hour, it is normal. Okay, so if the GFR, it is based on the age of the patient and the age of the patient, weight of the patient, and the creatinine value, they will be making some calculations. There is a formula for that. NCLEX is not worried about that formula. Based on that, they will be staging the patient, and they will be giving different stages. And fifth stage, stage 5, we can see that the glomerular filtration rate, that means the amount of blood filtered by kidney in a minute, is very less, and that's the end stage renal failure. Okay, so we are not going to by heart all these values. Just for your understanding, I gave you these figures. Okay, what are the causes of acute renal, chronic renal failure? So we have seen many patients, definitely when you complete your graduate nursing program, must have seen at least a few patients with chronic renal failure and dialysis. And it is basically the age. As the age increases, our kidney's capacity to filter blood is decreasing, as is every 10 years. The glomerular filtration, there will be a reduction in the glomerular filtration or GFR rate. Okay, so as age advances, the kidney's functioning can be affected. Uncontrolled hypertension and diabetes. So most of the patients, if they have a chronic renal failure, definitely they must have not controlled their diabetes and hypertension. They must have not taken medications. They must have not diagnosed that condition. That must be the leading cause of chronic renal failure. Acute renal kidney failure, as we discussed earlier, if you're not treating, if you're not identifying the cause of acute renal failure, that leads to chronic renal failure. Glomerulonephritis, any inflammation or infection of the nephrons, that leads to chronic renal failure. And autoimmune diseases like systemic lupus erythematosus and other autoimmune diseases like Hashimoto's disease and stuff like that. So that affects the kidney's function and leads to chronic renal failure. How we diagnose this condition? The mainly diagnosed by creatinine level. As I told you, creatinine is the pure indicator of your kidney function. Okay, so creatinine clearance test, and we know that it is no more in frequent practice, this creatinine clearance test, but NCLEX is interested in some aspects of this creatinine clearance test. So we'll quickly see what is that. So in this test, we'll be collecting 24-hour urine, and the first collected urine will be discarding. Suppose if you're starting the test today 8 a.m. So you'll be instructing the patient to pass urine into a clean container, and that urine will be collected. But if you're starting at 8 a.m. today, you'll be discarding the first sample. Then from the next sample onwards, you'll be collecting all the samples for 24 hours till the next day 8 a.m. You'll be collecting all the urine sample, and you will be checking the level of creatinine in the urine, and also so that is not a sterile container. In a clean container, you'll be collecting the urine, and you'll be withdrawing some blood as well. And there are some formula and calculation for doing that creatinine clearance, and based on that, they'll be deciding whether the patient is having chronic renal failure and on which particular stage of chronic renal failure the patient is in. So that is not an issue, but there'll be definitely the NCLEX is mainly focusing on whether it is a sterile container, whether it is a midstream urine. So it is not a midstream urine, it is 24-hour urine we are collecting, and it is not in a sterile container, it's a normal container, and the first specimen has to be discarded. Okay, so these are the 3 points you'll be keeping in mind if you get a question about creatinine clearance test. Okay.
So is there any solution in the container or just an empty container, or we?
There is no. It used to be in a. They'll be placing some ice cubes, and on top of the ice cubes they'll be placing a clean container, and into that they'll be collecting all the urine.
Oh,
No
okay.
further
Thanks.
specimens will be added to that.
Okay.
Okay. Okay, so that's about creatine clearance test in brief. And moving on to the signs and symptoms of chronic renal failure, we know that the kidney is not functioning. It is so the patient is not passing much urine. It's in a stage of oligouria. That means less than 400 mils of urine in a day. And blood pressure, all the fluid is accumulated in the body because the kidney is not functioning. Kidney is not filtering any urine. So there will be high blood pressure because of the fluid accumulation in the body. And in a stage of hypertensive crisis, the patient will be having, definitely there is fluid overload and there will be hypertension, headache, nausea, vomiting, and changes in the status. So this is a priority if the patient is having any hypertensive crisis. If the hypertension is not under control, if the patient is having headache, nausea, vomiting, and changes in mental status, that's a priority. So we have to intervene immediately. So whenever you get a question, and if the signs and symptoms of renal failure shows headache, nausea, vomiting, and changes in mental status, definitely that's a priority. Pulmonary edema, because there is fluid overload. The fluid can accumulate in the lungs and can cause pulmonary edema and crackles. There will be crackles. Bounding pulse, because there is fluid overload. Definitely there will be bounding pulse. Jugular vein distension will be present because all the veins, all the arteries, everything is distended and it is filled with extra fluid. Anemia, because there is thinning, like though there is extra fluid, so there will be definitely the patient will be having anemia. And also we know that erythropoietin is something which is produced by the kidney. So if the kidney is not functioning, definitely erythropoietin level will be less and the patient can develop anemia. Complications, there will be increased level of urea and pruritus. So the patients will be always having that itchy feeling. Oh, something is, a mosquito is pressed, mosquitoes are biting me. All those complaints the patients will be giving. It is not because of any mosquito or anything. It is because of the urea crystals and the waste products accumulated in their body that can be sketchy. So always they'll be having pruritus or urea because of the urea crystals. And hypernatremia, because the patient is having swelling. It is always associated with hypernatremia and swelling. If there is water, wherever there is water, there is sodium. So hypernatremia will be present. And high potassium, because these waste products or the extra electrolytes are not balanced or filtered by kidney. So there will be hypernatremia, hyperkalemia, but more than hypernatremia, hyperkalemia or high potassium is a priority because it can affect your cardiac function. And high phosphorus level is also noticed in this stage. So if there is high phosphorus, there will be low calcium, and this leads to osteoporosis in patients. So calcium supplements should be given. And as we discussed earlier, hyperkalemia, there are three different stages or three different, based on the level of potassium, the presentations can vary. This is something which NCLEX likes a lot. So they will be giving you in the question, what's the level of potassium. Suppose if it is between 6 to 7 milliequivalents per liter is given in the question, the answer options, one option will be a peaked T wave. Okay, so if it is between 6 to 7 milliequivalents, it is a peaked T wave. If it is between 7 to 8, there will be ST elevation as well. And over 8, there will be a wide QRS complex. Okay, so this points will be keeping in mind when you choose the options. Okay, what is the treatment of hyperkalemia? So the patient's kidney is not functioning. The patient is having oligouria, hypernatremia, and hyperkalemia. But if the question says if there is any cardiac issue, then you have to select options in a, you have to use bit trick to select your options. So all these modes of, all these are methods of treating hyperkalemia. The calcium gluconide, IV calcium gluconide is the best method of fixing dysarrhythmia. Suppose, so if the option is, so if the patient is having a high potassium level, the first option or the priority option that you'll be selecting will be IV calcium gluconide. And the second option is IV, actually it is regular insulin. Regular insulin, when you give, the insulin has a capacity to push all the potassium into the cell, and there won't be much potassium in the blood. All the potassium will be pushed into the cells, and in the intravenous, in the fluid, in the normal fluid, body fluid, the level of potassium will be very low. But the thing is that if the patient is on regular insulin, there is a chance that the patient will go to hypoglycemia. Because of that, we'll be adding always IV 50% dextrose. Then we'll be giving regular insulin to the patient to reduce hyperkalemia. And K-Exelate, as I told you, we can give it orally or as an enema. But this will be this will take few days to act, or it is not a quick. It will not quickly relieve the amount of potassium present in the body fluids. So it is a slow, or regularly we'll be using that. So so that's not an emergency management. Okay, and dialysis is the ultimate option for removing excess potassium from the body. Okay, so keeping all this in mind, we are going to discuss one question. Amanda, can you read it? Amanda? No? Samriddhi? Samriddhi doesn't want to read? Ravlin? Okay, Samriddhi is ready.
Patient with chronic disease, kidney disease missed pre-dialysis session, potassium level of 8.15, urine RS complexes, heart rate of 58, and lethargy. Which order should the nurse implement first? First one, IV 50% dextrose and regular insulin. Second, sodium cholesterol, sulfonate. Third one, hemodialysis. Fourth one, IV calcium gluconate.
Okay. So which order should the nurse implement first? So there are these 4 options she can select. And which one she'll be giving some priority here.
Calcium
And she has to number
4.
Number 4, calcium gluconide is the first option we'll be giving. That will fix all the arrhythmias. So calcium gluconide is the first option. We are selecting the option number 4. And if the patient is once stable, then we can go for option number 1 and option number 2, and ultimately for option number 3. All the options are correct, but we are selecting the first order, or the which one to be implemented first. Okay, next one. Who wants to read? Volunteers? Anyone read?
A nurse is caring.
Okay, now you're confused. Yeah. Richa can. I think Richa is reading. Or Samriddhi. I think she didn't get an option. Well, she didn't get a chance. Yeah, yet.
A nurse is caring for a client with end-stage renal disease with potassium 7.2 milliequivalent per dl, burn 35 of 8.3, 3.8, and urine output of 30 ml, 30 ml per 24 hours. Which order is priority? First one is IV regular insulin and 50% dextrose. Second, IV loop diuretic. Third one is dialysis. Fourth one is administering calcium carbonate.
Which option?
Option 1.
Option 1. Easy, right? Easy, right? It's a direct question. So the option is IV, regular insulin, and 50% dextrose is the option. Okay.
Ma'am, I have
Okay.
one question.
Okay.
If it's written there like IV regular insulin and 50% dextrose, I think it's a hypertonic glucose. If we got other option like regular insulin plus 25 dextrose, then is it wrong or it's also right? Like, or only 50% dextrose we can given in this case? Like,
in some dextrose is okay, but mostly they will be giving an option of 50% dextrose because that's a commonly used for patients with renal failure and to control hyperkalemia. There'll be, because if it is normal saline, definitely you cannot choose that option.
yes,
If there
yes.
is, you think that's the most appropriate one, you can select. If there is some dextrose in that, that could be fine.
Okay. Most commonly, so 50% dextrose we can use it.
This will be given. This combination is given for patients with high potassium level.
Okay, thank you.
Nursing interventions. So we know that some of the nursing interventions that we have to follow, in case of end stage of renal patients with renal failure is daily weight check. If the patient is having a 1 kilogram weight gain, that means 1 liter of fluid is accumulated in the patient's body. So that has to be reported immediately. That's 1 liter. That's significant. So every day we'll be checking the weight. If there is more than 1 liter of weight gain in a day, that has to be reported immediately. And avoid all the something that destroys further kidney damage, that has to be avoided, like NSAIDs. We have already discussed, they are dangerous. Antibiotics, which are the 2 antibiotics which we mentioned that kills kidney?
Vancomycin,
Gentamicin.
Gentamicin. And milk of magnesia, it is not good for the renal function, like if there is an impaired renal function. So we have to avoid milk of magnesia, NSAIDs, antibiotics, and CT contrast. Nurse's responsibility, of course, we have to restrict fluid, maintain eye intake and output chart, no sodium, because the patient is in a stage of hypernatremia. No canned food. All the canned food will be having excess amount of salt or any substitute of salt. So all canned food, canned fish, canned berries, or whatever it is, we have to avoid all canned food. No processed meat. Okay, so all this, like not the fresh ones, even the fresh ones we won't recommend, because it is meat and it is rich in protein, and ultimately that will increase the urea and creatine level. So we won't encourage the patient to have meat as well. Especially processed meat, will discourage the patient to have processed meat. No potassium. If we'll be discussing about potassium rich food in the later slides. Apple is the best option for patients with high potassium. No salt substitute. So instead of salt, they may be taking some salt substitute. So that is also not encouraged. Low phosphorus and low protein. So no yogurt, no pudding. So all these things will be keeping in mind. All these things will be teaching the patient to avoid. Okay. So basically, if you check the diet of the patient cannot have anything tasty. The food will be completely bland, and if this patient is eating, that will be against. So it is a very difficult situation for the dietitian, nurse, and the patient to deal with. The chronic renal failure is such a I don't have words to say the amount of the condition of the patient. Okay, potassium rich food. So what are the potassium rich? So there is an easy acronym that we can use to remember the potassium rich food. Okay, POTASSIUM. Okay, potassium: potatoes, oranges, tomatoes, avocados, strawberries, spinach, fish, mushroom, and muskmelon. So they will be giving one particular option from any of this thing will be given in the option, and they will ask you to select which is the best food for chronic renal failure patient. So you have to keep potassium in your mind, and so if you expand the acronym, you'll be getting the answer. Okay, simple question, direct question. Who will read it? Sandhu? Sandhu is not attending. I will ask Kajal to read if Sandhu is not attending. Is Kajal attending?
Yes, ma'am. A client with
Okay.
chronic kidney disease has blood laboratory result with high potassium. What is the best afternoon snack to provide to this client? Number 1, apple slices with caramel dip. Number 2, chips and avocado dip. Number 3, non-fat yogurt with orange slices. And number 4, vanilla pudding with strawberries.
Yes, easy question, right?
Yeah. Number 1.
Apple slices with caramel dip. Why you didn't select second option?
Because there is avocado potassium.
Yeah, potassium rich. Avocado is potassium rich, so we are avoiding that. And chips most probably, chips, it will be rich in salt, right? So we are not giving. Non-fat yogurt with orange slices, orange, right? And it is chronic kidney disease. And whether we prefer yogurt? No. Vanilla pudding, strawberries rich in potassium. So we are not giving all that options. Quickly about dialysis. It's time to take a break. Exhausted? Need a break now or later? Jacob is asking for a break.
Yes, ma'am. No.
Okay, now we'll go for a short break. Usually, how many minutes you get a break?
10
minutes.
10 minutes. Okay, so take 10 minutes break and join back. Thank you so much. Welcome back after the break. Okay. So okay, are you all back after the break?
Yep.
Are you attending?
Yes, ma'am.
Okay, so quickly into dialysis. So that's the final option if our kidneys are not functioning, right? So this is like an artificial kidney. That is, there are two types of dialysis, that is hemodialysis and peritoneal dialysis. In hemodialysis, blood is taken out from the body, and that is passing through a machine called dialysis machine, and the purified blood will be coming back to your body. Whereas in peritoneal dialysis, you are not taking out anything from your body. A dialysis solution is instilled into your peritoneal space, and peritoneal membrane will act as a dialysis membrane. Then there will be exchange of waste products, and the stuff will be taking place. And the peritoneal dialysis we can perform in our home setting, whereas hemodialysis we have to go to hospital, and there we'll be performing hemodialysis. So the nursing interventions, some of the nursing interventions are common, but some are specific for hemodialysis and peritoneal dialysis. So so actually some slides got mixed. But before dialysis, we have to always assess the fluid status of the patient. Before hemodialysis and peritoneal dialysis, definitely we'll be checking the weight of the patient, because today if you're doing the dialysis, immediately after dialysis, you'll be weighing the patient, and you'll be recording the patient's weight. And when the patient next time come for the dialysis, definitely you'll be checking, before doing the dialysis, you'll be checking the weight of the patient. So that much fluid the patient has accumulated in the body. So that way we are assessing the fluid status of the patient. And in case of hemodialysis, they will be creating a fistula. Fistula, as you all know, it's an abnormal connection between an artery and vein, and it will take 2 to 4 months for the maturation of fistula. Then we'll be starting with dialysis through fistula. Assessing the fistula site is very important in dialysis, because fistula, so what all things you have to check if the patient is having fistula? Any any special precautions you'll be taking, or what all teaching you'll be giving to the patient if the patient is having a fistula?
Do not take blood pressure on that.
Yeah. Bensi, can you answer a few instructions for a few teachings that we will be giving to the patient if the patient is having a fistula? Do not take blood pressure. That's good. Other than that,
no puncture on that side.
Okay, should not puncture, should not collect blood from fistula. So we'll be feeling like we'll be having, okay, this is a good vein, we can puncture. So if it is that should not do that. Okay. No blood collection.
Do not take too much weight in that hand.
Yeah, if you're having a fistula in your left hand, do not hold much weight in that particular hand. Okay. Anything else?
Don't lie down with that hand.
That side, you should not lie down with the affected side, or the one with which is having a fistula. What else? Daily you have to check whether the fistula is functioning properly. How you will check?
With the thrill and root.
Thrill and root. If there is no thrill and root, what it indicates?
It's not functioning.
It's not functioning. With the stethoscope you can auscultate, or with if the patient is not feeling that vibration, then we have to inform the patient. We have to teach the patient to immediately report that to the healthcare provider. Okay, so that's about assessment of fistula. And before a dialysis, is it good to give medications before dialysis, all the medications will be finishing, then we'll be sending the patient for dialysis. Is that good?
No, no.
No, ma'am.
No, because all the medications will be
Cleared out.
Filtered.
removed by the, or filtered by the artificial kidney. So it is not good to give all the medication. And on top of that, they are this medications like all the blood pressure reducing medications or hypotensive agents like our ACE inhibitors, beta blockers, calcium channel blockers, they already reduce the blood pressure of the patient. So if you give like this medications even before dialysis, that will reduce the blood pressure. And on top, the dialysis is taking out the fluid from the body, especially hemodialysis. So this will further reduce the blood pressure of the patient, and there will be a sudden collapse. The patient can suddenly become unconscious because of hypotension, severe hypotension. So it is not recommended to give all these medications before, especially before dialysis. Okay, diuretics, any dilators kind of medications will be holding all the medications, and after the dialysis, we can start giving all these medications. Which are the two medications which NCLEX is okay with to give for the patient who is going for dialysis? Have any idea?
Antibiotics, ma'am.
Which one?
Antibiotics.
No, antibiotics. We cannot give antibiotics.
Supplements.
Which one?
Insulin.
Insulin is one drug which is mostly for most of the NCLEX exams. They have shown that insulin is okay because it will be acting quickly, and so insulin is okay before giving dialysis, and also calcium supplements. It is okay to give calcium supplements and insulin, but all other drugs, before dialysis, it is not recommended. Okay. Okay, now into peritoneal dialysis, we'll come back to hemodialysis. Before that, peritoneal dialysis. So we know that there is an abdominal lining that is known as peritoneum. It's a semi-permeable membrane, and to dialyse a client so usually this is performed in a home setting. This is preferred for most of the patients because they can function normally. Because there will be a catheter attached to their abdomen, and after use they can cover that and they can function normally. They can come for here in Australia. I met a lady who is undergoing peritoneal dialysis every day at home, and she's coming for her studies. So it is that common that we can, in Australia, we know that the medical facility, the Medicare card will be covering all the expenses. So people are very comfortable with procedures like peritoneal dialysis, whereas hemodialysis, we have to go to a doctor, we have to go to a healthcare facility or a hospital. There they'll be doing a dialysis. Okay, so just a catheter will be placed to the abdomen. I mean, that will be already inserted, and that will be secured there. To that, they will be connecting a dialysate or a solution. So they will be this is just like an IV solution. They'll be hanging somewhere, and that will be connected. That will be when they open that, just like if the connector is open, the fluid will flow into the peritoneum, and it will remain in the peritoneum for at least, once the entire fluid enters the body, then it will allow in the peritoneal area for at least 30 minutes. So that's a dwelling phase. And after that, they'll remove another tube, so that will withdraw all the solution from the body. So with that, the blood is getting purified. Okay, so that's peritoneal dialysis. The catheter is then unclamped and allow the dialysate to drain via gravity. So if there is any insufficient outflow, if we are observing any insufficient outflow for the particular dialysate solution, then it can be because of constipation. If the patient is having constipation, then it can be because of some position. So if most of the patients night time when they are sleeping, just before sleeping, they'll be connecting that, and after the they'll be awake till the dwelling period. Once the catheter is unclapped, they can sleep, and till then by 4 to 5 hours, the entire dialysate solution will be out, and they can wake up and they can do their normal routines. So most of the cases, what happens, if the patient is sleeping, they will be changing their position. That can be a cause that will obstruct the outflow of dialysate. So in that case, we have to provide a proper sideline position for the patient. And also sometimes it can be because of constipation. Okay, so in this image you can see there will be a solution bag, and there will be a connector, and a catheter is inserted. This will be catheter will be a fixed thing. Only to the connector, the tubings will be connected, and there will be a drainage bag. To that, the drainage will be collected. Okay. Okay, so during the installation and dwelling portion of the cycle, the client, if they are in the hospital, or initially if they're beginning with the peritoneal dialysis, they will be in a healthcare facility, and the patients will be monitored continuously for respiratory distress, because we are injecting some solution into the body. So there is a chance that that can be an excess solution, and that can reach up to the lung, and there will be pulmonary edema and difficulty in breathing, rapid respiration, crackles. So we have to always observe the patient for any respiratory distress. Okay. Yeah. Okay, so that may overfill the abdomen, and it can reach up to the thoracic cavity and fill in the lung. So that's what we have to monitor in case of peritoneal dialysis. So as nurses, if the outflow is reduced, if there is a sluggish outflow, nurse should assess the client's bowel pattern. If there is any constipation, an appropriate medication has to be administered. And nurse should also check the tubings for kinks and repositions. But you should not inject, or sometimes if there is a block in IV cannula, we'll be pushing some fluid into the cannula, right? That is not possible in this case. You should not push any fluid or any dialysate forcefully into the abdominal cavity. But whereas if there is any kinking, that you can make it proper, like if kinking can be checked, and reposition of the client to a sideline position, all that can be given. Drainage bag should be maintained below the abdomen, because this is working purely on gravity. So that if the drainage bag is on the bed and the patient is also on the bed, definitely the flow will be sluggish. The nurse should assess for fibrin clots and milk the tubing. Some amount of pressure we can give, and milking of tubing is okay. And so whether the tubing is having any fibrin clots, that we have to as if it is noted, then we have to inform the doctor, and the doctor will be starting any fibrinolytic agents like alteplase. If these measures are ineffective, an X-ray can be taken and will identify whether the catheter is placed properly in the peritoneum or it has dislodged. Complications. We know that we have to perform a good hand hygiene before starting this particular procedure, and dialysate solution will be keeping in the will be storing the dialysate solution in appropriate temperature, and we have to warm the dialysate solution. It should not be hot, but it should be of body temperature. Otherwise, this will cause shivering and other reactions in the patient. Okay, so it is essential to follow all the sterile techniques when spiking and attaching bags to dialysate. And also, the most important complication is bacterial peritonitis. It is an infection of the peritoneum, and if there is any fever or any chills, if the patient is having that is very important. That has to be reported immediately to the healthcare provider. If the dialysate solution is cloudy or effluent, if the patient is having tachycardia, low-grade fever, these are the signs of peritonitis. Small question. Manjot Kaur, right? Yep, Manjot Kaur, right? Yeah. No, M-A-I-N. Me, it's spell it. I don't know how to spell. How to pronounce it? Is it Banjot? No. I think now Jyot has to read now.
Navjot, ma'am.
But I can say M-A-I-N-J-O-T. Is it Navjot? No. It's a different
No.
person, I think.
Yes, ma'am.
Anyway, Navjot will read it now.
Okay. The nurse assesses a client receiving peritoneal dialysis. Which assessment finding are most important for the nurse to report the healthcare provider? Select all that apply. Cloudy outflow, low-grade fever, liguria, proctitis, and a tachycardia.
Yeah. So the options, just now we discussed.
1 to 5.
Cloudy outflow, low-grade fever, oliguria, pruritus, and tachycardia. Cloudy outflow, that indicates effluent, there is a chance of peritonitis. Low-grade fever, peritonitis, and tachycardia is also seen in peritonitis. What about oliguria?
Is normal.
Is an expected finding. Is an expected finding of patients with renal issues. Pruritus?
Yes, expected.
It's also
It is expected. It is, why there is pruritus for patients?
Because of renal
because of uric acid crystals, right?
Yeah.
Okay. Next question. We'll read it. Isuru?
Can you show the answer, please? The previous one.
1 second. Yeah.
Okay. Thank you.
Next one.
Yes, ma'am.
Yeah. Who's reading?
The nurse assesses a client during the dwell time of a peritoneal dialysis cycle. Which assessment would require immediate intervention? First one, blood pressure of 168/88 and pulse of 72 per minute. Client experience intermittent nausea, crackles present in the left and right lung spaces, presence of 1+ pitting edema in ankle and feet bilaterally.
The patient is in the dwell time of peritoneal dialysis. What is dwell time?
When we instill the diastole, so it's the dwell time, like 20 to 30 minutes.
So we'll be waiting. Yeah, so that waiting period is dwell time. So during that period, the patient developed a blood pressure of 168/88 and a pulse of 72. The client is experiencing intermittent nausea. Okay, and there are crackles present in the left and right lung base. And there is presence of pitting edema in ankles and feet. So this is, the patient is undergoing peritoneal dialysis. Definitely the patient's kidney is not working. So some findings are expected and one is not expected. It's a sudden development of something happened. Yeah. So what could be that?
Third one, which need immediate
interventions. Why?
Yeah. Because I think it's a sign of fluid overload.
Yeah, the fluid, the abdominal cavity must have filled and it has gone up to the thoracic cavity and there are fluid in the lungs. So that's why there are crackles present in the left and right lung base. So that is something very that we have to immediately stop. We have to immediately give some interventions. We have to immediately inform that to the immediate intervention and attention is needed at this particular stage. Okay, so the third option we are taking. Okay. Okay, next question. Who will read? nobody's ready, Kajal will read.
Ensure that the drainage collection bag is.
Who is reading? Amanda is reading.
Okay. The nurse prepares to install the dialysate for a client receiving peritoneal dialysis. Which nursing action is the priority? 1. Ensure that the drainage collection is below the level of abdomen. Number 2, place the client in a semi-fowler position. 3, record the characteristics of the output dialysate. Use a sterile technique when spiking and attaching the bag of the dialysate. I think it's 4.
It's 4. It's clear, right? And the question says the nurse is preparing to instill. So the nurse is in a stage of preparation to instill. And they have the third option is recording the characteristics of output dialysate. So definitely we can't select that. Placing the client in semi-Fowler's position. Actually, the patient can be in supine position. If the flow is obstructed, then we will be giving a semi-Fowler's position, because the patients, most of the patients, they will be sleeping during their they can be in their comfortable position. But in case if you feel there is obstruction, then we'll be giving a semi-Fowler's or a better position. Okay.
And sideline
and it is just preparation, and the most important thing is prevention of peritonitis. So we have to use a sterile technique when spiking and attaching the dialysate. Good, Amanda. Next one. Who will read it? My God, Ravlin.
Yes, ma'am. The nurse is caring for a client whose peritoneal dialysis is beginning to exhibit insufficient outflow. What action should the nurse perform initially? Select all that apply. First, assess for abdominal distension and constipation. Second, contact the client healthcare provider. Third, examine the catheter for kinks and obstruction. Fourth, flush the tubing with 100 ml of dialysate. Fifth, place the client in a sideline position.
Select all that apply, right? Yeah.
Yeah.
There is insufficient outflow. So what we can do?
1,
3, 5.
And 5.
1, assess the abdominal distension and constipation. Okay, 1 you're selecting. Okay with that. Second one you're selecting? Are you selecting the second option?
No.
No, because when we contact the healthcare provider,
When it's not
they ask
initial
you what
steps.
you. Yeah, we have to think about that before whether we can solve that issue. Okay, third option, kinks and obstruction. Examine yes. So option 1, option 3, option 4. Are we selecting option 4?
No, ma'am.
Yes or no?
No, ma'am.
No.
No flushing. No flushing. Milking is okay, but no flushing. Okay. Fifth one, place the client in a sideline position. Yes. So we are going with the option 1, option 3, and option 5. Right. 5. Yes, we are right. Moving on. Okay. Just about the creatinine clearance, which I already told you. Creatinine clearance is a measure of glomerular functioning, a sensitive indicator of renal disease progression. So in this case, a 24-hour urine sample is collected. So the first specimen is discarded and the time is noted. And next 24 hours, the urine is collected in a container and kept it in a cool place. At the end of 24 hours, the client should, at the end of 24 hours, the client has to void again, and that specimen has to be added to the container, and blood will also be withdrawn to check the level of creatinine. Okay, so this is creatinine clearance test. A question from this section. So this will be a direct question. Linimol. Linimol?
A client has been given instructions about collecting a urine specimen to test creatinine clearance. The client indicates correct understanding of the specimen collection procedure by making which statement? First one, if a catheter is placed temporarily, then removed after one void. The second one, I must provide a midstream sample in a sterile container. Third one, I will need to collect all my urine in a container for 24 hours. Specimen is best as it is more
Yeah. So which option?
Third one.
I will need to collect all my urine in a container for 24 hours. So it is not the midstream one. It's not the first specimen. And we don't have to catheterize the patient. Okay. Yes. Next question. Samriti. Samriti has Friday evening duty. Samriti is not joining us. Who will read it? Jacob? Jacob, I think he has evening duty as well. Jacob is reading.
Client diagnosed with end-stage renal disease comes to the dialysis clinic for treatment. Which actions should the nurse take to prepare the client for hemodialysis? Select all that apply.
Okay.
Administer subcutaneous heparin to decrease clotting during dialysis. Administer client morning doses of carvedilol and lisinopril. Check the client's medical records to determine the last post-dialysis weight. Obtain a set of client vital signs and the client's current weight. Palpate the fistula in the client's arm for a thrill and auscultate for a bruit.
Yes. The patient is having end-stage renal disease, and he has come to you for dialysis, and you are the nurse there, and you are preparing the patient for dialysis. And what all interventions you'll be doing when you're preparing the patient for dialysis, right? Okay. Jacob, you're the nurse now. You have to decide what you're going to do there. First option.
No.
No?
No.
Okay. Second option?
No, ma'am.
No, ma'am.
No,
Why?
No. Maybe there are some chances of hypotension dialysis. So
Yeah, so we're not giving. So okay, so Jacob is not going for subcutaneous heparin. He's not giving antihypertensives. Okay, third one.
Yes, ma'am.
Yeah.
Yes, he is checking the last post dialysis weight, and he'll be checking weight. When he'll be checking the weight again.
Yes, ma'am.
Before the dialysis.
We have to check the weight
Before and
start.
after.
Yeah, before and the last post dialysis weight. He'll be checking. You'll be checking, and you'll be comparing how much weight the patient has gained. Okay. So the third option, okay, Jacob is checking the weight, the medical record to determine the weight. Okay. The fourth option.
Yeah, it's correct.
Yes, correct.
Definitely, we have to check the vital signs of the patient and client's current weight. Okay. So you're doing vital signs, you're checking the weight, you're checking the medical record. Okay. Fifth one.
Check for the patency of.
Yes, you have to check the fistula, whether there is a fluid thrill is present. Thrill is present in the fistula, and you have to auscultate the fistula for any bruit. Okay. So if this, so you are selecting the option 3, 4, and 5, right? You're right. Okay, so you must have heard about dialysis disequilibrium syndrome, right? It's a rare complication of dialysis. This is commonly seen in if the patient comes for dialysis for the first time or the initial stage of dialysis. This is commonly seen. This is because all of a sudden the waste product like urea and creatinine, which was present in the blood, which is completely taken out, and there will be a concentration gradient is developing between and the whatever is taken out, and it seems the area will be filled with fluid, especially in the brain cells, and that will lead to increase in intracranial pressure. So it is typically seen in the initial stage of dialysis or when they are doing dialysis for the first time. So the patients will have a nausea and vomiting. Especially we know that it will be projectile kind of vomiting because the patient is having a high intracranial pressure, and it's a case of intracranial pressure. So definitely there will be headache for the patient. The patient will be restless and change in mentation. That means the patient will be a kind of agitated and confused. Okay, and there is a great chance that the patients can develop seizure as well. So if the patient is starting with the in the initial stage, if you're finding the patient is having some of any of these symptoms, so then the option is we have to immediately reduce the rate of dialysis or stop the dialysis procedure, because this is a complication of dialysis. All of a sudden, if we are completely removing all the waste products from the body, then there will be increase in intracranial pressure, and that leads to all these complications. So if we are not treating all this condition, if we are not giving proper attention, that can even lead to death because of cerebral edema, and the patient will go to a stage of coma. Okay, so this we have already discussed before. We are creating an arteriovenous fistula for hemodialysis. This is a connection between an artery and vein, and it will allow the quick blood flow, and it will take 2 to 4 months for the maturation of the arteriovenous fistula. And NCLEX likes arteriovenous fistula very much. How to teach, what all teachings we have to give, what all instructions we have to give to the patient before they go for an arteriovenous fistula care. Okay, so if there is any numbness after this arteriovenous fistula formation, if there is any numbness on the distal part of that fistula, suppose if there is a fistula on the arm, and if the patient is having numbness in the fingers, then that has to be reported immediately, because the patient is not having proper blood supply to that particular fingers, and that has to be reported immediately, and we have to make sure that there is proper blood circulation reaching to that area. Otherwise that fingers or that particular arm can become paralyzed, like paralyzed condition, because of the reduced blood supply to that particular area. Okay, so just reminding you once again about arteriovenous fistula, because it is important, and NCLEX is very particular about arteriovenous fistula. So do not allow anyone, including the dialysis personnel, to draw blood pressure from that particular extremity. Avoid wearing any restrictive clothing or jewelry. So if the patient is having an AV fistula, the patient should not wear watch or bangles on that particular arm. Do not use arm with vascular access to carry heavy objects more than almost 2.25 kilogram. However, exercise, like we have to do a regular exercise with a soft ball or a sponge, by squeezing that soft ball or sponge, because that will increase the blood supply, and that will help in the maturation of arteriovenous fistula. Check the function of the vascular access daily by feeling the vibration. The patient cannot auscultate, but the patient can feel the vibration. But whenever the patient is coming to you, to a nurse, she has to auscultate for any bruit. Do not sleep on the arm with vascular access. Use creams and lotions on the site. Monitor for signs of infection and bleeding after dialysis, and If there is any immediately after dialysis, we have to check that area whether there is any bleeding from that particular area. Keep the fistula site clean to help to prevent infection. A direct question. Who will read it? Arya? This is the first question for Arya. Is Arya attending her evening duty? Deepa? No, Deepa is not here. I think I'm always asking question to Navjot. They all left the meeting. Okay, Navjot, can you read it?
Yes, ma'am. A client with chronic kidney disease has a subcutaneous arteriovenous fistula placed in then on the dominant left rest for hemodialysis. Which of the following statements indicate the client understand how to care for the fistula properly? Select all that apply. First, I do not need to call my healthcare providers if I have numbness or tingling in my left arm. I will make sure I always have my blood pressure taken in my non-dominant arm. I will squeeze a small sponge with my left hand several times a day. I will touch the site and feel for a vibration several times a day. I will try not to sleep on my left arm.
Answers, please.
3, 4, and 5.
3, 4, and 5. Quick answer. First one, I don't need to call my health provider if I have a numbness. Definitely, we have to tell them to inform the health care provider because there is lack of blood supply to that particular area. I will make sure I always have my blood pressure taken in non-dominant hand. No, because it's a left hand is having a fistula, so it should not. 3, yes. The patient has to squeeze a small ball that will help in the maturation of fistula. I will touch the site and feel for vibration several times a day. Very good. And I will try not to sleep on my left arm. So options 3, 4, and 5. Yes. Next question. Who will read it? I can see only Binsi, Amanda, Gurpreet, and Navjot on my screen. All others are hidden. Any volunteers?
Yes, ma'am.
Read it.
The nurse is performing discharge teaching on nutritional therapy for a client with chronic kidney disease. Which statement indicates the further teaching is needed? Option 1, because I have chronic kidney disease, I should avoid canned soups and cold cuts and sandwiches. Second option, I can use a salt substitute because I'm required to restrict both sodium and potassium in my daily diet. Third, I must avoid eating raw carrots and tomatoes on my salads because I take hemodialysis in treatments. Option 4, the popsicles I eat should be counted in my daily fluid intake because they become liquid at room temperature.
Which statement indicate the further teaching is needed? The
option 2.
Second one.
Second one? Second one?
Yes.
Somebody said option 4?
Yes, ma'am.
Said option 4. Jacob? Okay, so the correct answer is I can use a salt substitute because I'm required to. Option 2 is the option because salt substitutes and salt itself should not be used, or we have to avoid salt substitutes. First option, correct, right?
Which side, ma'am?
Canned food. The patient is avoiding canned food and sandwiches. Okay, canned food must be having extra salt. The patient has to avoid that. I must avoiding eating raw carrots and tomatoes on my salad because I take hemodialysis as a treatment. What's wrong with that option?
High potassium in
High
tomato.
potassium.
High potassium, very good. And last one, fourth one,
The
popsicles. What's popsicles? That's basically, what's that, popsicles?
Ice cream.
That's ice, right?
Frozen ice
Yeah,
cream.
so this
Frozen
can be, this can become, this has to be added to my daily fluid. So the patient is aware that this is ultimately the fluid that is increasing the fluid level. So the option is 2. The further teaching is needed because the patient is taking salt substitute. Okay. Quickly into urinary incontinence. So we have seen elderly patients, especially females, they will have urinary incontinence. And it is because of the compression of the bladder by any other structure. It can be a prolapsed uterus, or it can be a enlarged prostate. So for some patients, their muscle strength of that particular area will be less, and that leads to urinary incontinence. But in case of patients with a spinal cord injury, they don't have any control over their bladder, and that leads to urinary incontinence. And diabetic neuropathy and some of the medications that will cause urinary incontinence. I think this is a question. Is that a question? Yeah, no. It's about the interventions. When caring for a client with overflow incontinence, the nurse should teach what all things to the patient, and what all teachings we have to give to the nurse. What all things the nurse has to teach a patient if the patient is having a urinary incontinence. Suppose an elderly lady is coming to you, she has urinary incontinence. How you will teach how to control urinary incontinence? The first thing what you can teach is, you can teach her that every 2 hourly, though whether you're feeling to pass urine or not, every 2 hourly you will be setting an alarm, and you will be visiting toilet, you will be visiting washroom, and you'll be passing urine. Okay, so that will avoid overfilling and overfilling of the bladder. So that's the first thing you can teach a patient. Second thing, instruct the client to use Valsalva manner. What is Valsalva manner? That is bearing down. So some patients, even like patients with prostate issues, some patients, elderly patients, they will not be voiding completely. So what they can do is, they can apply, after voiding, they can apply a gentle pressure, so that the entire bladder will be empty, or the bladder, there will be a better bladder empty. Okay. Third one, assess the perineal area for skin breakdown, because this urine will be continuously dribbling, and to avoid this is an issue that affects the person and its family, and the patient's family as well. So they will be using some pads continuously. So they may be using some measures to so that the urine will not leak, or so they'll be continuously using some pads or something. So what will happen if the body is continuously in contact with the urine? That area will be, there is a great chance that the skin breakdown of that area can happen. So we have to always inform the patient to check the area for any skin breakdown. Okay. Measure the post-voidal residual volume, because most of the hospitals, when the patient is coming or in the outpatient department, they have a quick simple scanning machine that will check the amount of fluid present in the bladder after voiding. So that is post-voidal residual volume. We can see that if it is more than 100 ml, we have to inform that to the doctor. Because there is large amount of fluid which is present in the bladder, urine is present in the bladder, that is not good. So we have to make sure we are doing that particular scanning, and instruct the client to wait 20 to 30 seconds after voiding, because after voiding, the patient has to wait for 20 to 30 seconds, then try for a second void, that is known as double voiding technique. So these are the measures which are effective in patients who are complaining of urinary incontinence. Hope we are going for a quick question. Who will read it? Oh my god. Ravlin. Ravlin, she has gone for duty. Ravlin is not reading. Monica?
Yes, ma'am.
Can you read it?
The nurse, yes, ma'am. The nurse is caring for a client with overflow urinary incontinence related to diabetic neuropathy. Which of the following interventions are appropriate? Select all that apply. First option, decrease fluid intake to 1 glass with each meal at bedtime. Second, encourage the client to bear down while attempting to void. Third option, inspect the perineal area for evidence of skin breakdown. Four, measure post-voidal residual volumes as prescribed. 5, tell the client to wait 30 seconds after voiding and then attempt to void again.
Okay.
Correct option 2, 3, 4, 5.
2, 3, 4, and 5. And the first option?
Wrong.
Wrong. There won't be adequate fluid intake for the patient if we are restricting the fluid, right? Okay. Okay. I think we have discussed all this. UTI we have already discussed, right? In patients with UTI, especially if you're working in a aged care facility, you can see that elderly patients, if they're developing UTI, definitely there will be fever and other symptoms. But if they are confused, so that's a time that you can, if the patient, if you're normally when you're visiting the patient, when you're taking care of the patient, if there is a slight change in their mentation, or if they're slightly confused, you have to do a urine analysis for the patient, because that can be, especially in elderly patients, the UTI can be manifested as a confusion, or there will be a change in mentation. So that is something you have to keep in mind when you get a question from UTI, other than burning sensation, fever, chills, and treat antibiotic before we have to send for culture and sensitivity. All that thing you have to keep in mind. Along with that, this particular point you'll be keeping in mind: if the patient's age is above 60 in the question, if the patient is having confusion, then what will be the nursing intervention? So they can formulate a question, because UTI and confusion, they are related, especially in elderly patients. Okay. Question, who will read it? Now I won't call out your name. You have to volunteer and you have to read.
The nurse is caring for a 78-year-old client with urinary tract infection. Which assessment finding would be most concerning and require immediate follow-up by the nurse? Confusion.
Definitely confusion is the answer, because the patient is having UTI. There is change in mentation. So the answer is this. Okay, now into bladder cancer. So bladder cancer, we know that the primary cause of bladder cancer is cigarette smoking and also other tobacco use. In addition to that, some of the occupational exposures, like carcinogen exposure, is a second, occupational exposure, like those who are working in mine, those who are working in some of the printing and painting, those who are doing with metal work, industrial painting, aluminum processing. All those are areas whether the patient is exposed to any of the chemicals, especially in the form of aerosols and vapors. That is very important. That can be a cause of bladder cancer. But the most important cause of cancer, as per the researchers, it is cigarette smoking. And a high amount of fat intake and artificial sweeteners, that cause artificial sweeteners are not at all good for our kidney and our urinary system. So this can also, there are some connections with the bladder cancer, but that is not a primary cause. A question that we saw in one of the famous question banks. So which health history information would be most important when we are obtaining a health history of a patient with bladder cancer? It is definitely the tobacco use is the answer. Okay. I think this is the last question. Quickly, we are going to let's stop my sharing. Quickly, we'll see about a few renal medications. Okay. Okay. So far, do you have any other doubts from the topics which we discussed?
No.
We don't have any doubts. Could you please wind up the session? That's what you're asking me? No? Okay. Let me share my screen again. Okay. Can you see my screen now?
Yes.
Yes. Okay, so some of the important drugs which we commonly discuss in under renal system, and the questions related, the commonly asked questions from renal system that we are discussing. The important drug, the first important drug that you remember is terazosin and tamsulosin. Terazosin and tamsulosin, they are alpha adrenergic blockers. They are mainly used in the treatment of benign prostatic hyperplasia, that big enlarged prostate. Okay, so we know that it is a big prostate, and the passage of urine is obstructed because of this big prostate. So what this terazosin and tamsulosin, they are alpha adrenergic blockers. What they do is they'll relax the smooth muscles of the bladder, neck, and prostate gland. So since they're relaxing the smooth muscles, they're not only relaxing the bladder, neck, and prostate gland muscles, smooth muscles, they are relaxing all the other smooth muscles. So we know that we have some peripheral smooth muscles. We have, so that will be helping to maintain the normal blood pressure. So if the patient is taking this smooth muscle relaxant, all the muscles will be relaxed, and there is a great chance the patient can develop hypertension. So whenever the patient is taking this medication, we have to keep in mind, or we have to educate the patient that this will cause hypertension. And we have to also teach the patient that it is better to take this medication at bedtime. So the patient will be having the medication, and the patient will be sleeping. By the time the patient get up, he will be out of this the action, and there's a less chance of fall for the patient. So this will be keeping in mind if the patient is taking alpha adrenergic blocker. The mainly commonly asked names in NCLEX is terazosin and tamsulosin. Okay, so the patient teaching points, the client should take the medication at bedtime. And since there is a huge risk for hypertension, the patient has to change the position very slowly. When he is getting up from the bed, he has to sit for some time, then he has to stand for some time, then he has to start walking. And one of the important thing about tamsulosin and terazosin is that most of the medication that should not be mixed with grape juice. But fortunately, this is some of the particular medications which we can mix with grape juice and give it to patient. Avoid medications that also increase smooth muscle relaxation. So we know that some of the other medications like any other relaxants, if the patient is already using, so we know that it is this tamsulosin and terazosin we are giving to elderly patients, about after their 60s. They may be in their 60s or above, and they may be having a big enlarged prostate or benign prostatic hyperplasia. They may also be having some other sexual disorders like ejaculatory some erectile dysfunction and problems like that. So they may be having a Viagra or sildenafil, they may be already taking. If the patient is taking that is already a smooth muscle relaxant. On top of that, if you add this drug, there is a great chance that the patient will go to a stage of hypertension. Okay, so this we have to keep in mind. A quick question from that. Who will read it? Volunteers, please make it fast. We have a few more slides to complete before time.
The healthcare provider is starting an elderly client on terazosin to treat benign prostatic hyperplasia. Which information should be included when teaching this client about new medication? Change position slowly when going from lying to standing. That's correct option. Do not drink grapefruit juice. That's wrong. Take this medication first thing in the morning before breakfast. Wrong. Your stool may become darker. That's not significant in this. Option 1 is the correct.
Okay, okay. In which particular drug the stools become darker?
Iron.
Iron supplements.
Iron,
Iron supplements.
Iron supplements. Okay. 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 Next important drug that we discuss in urinary system is your Lasix. Lasix, we know that it is a loop diuretic. Okay. So when the patient is taking loop diuretic, what will happen? What will happen? There will be excess
Urine output.
excess urine output will be happening. So what happens to the potassium level? Whether the potassium will be
It goes down.
Okay, so along with the urine, this will be excreting potassium as well, because furosemide, it is not a potassium sparing diuretic. Okay, whereas there is something called spironolactone that will spare the potassium, so that will not excrete potassium. Whereas furosemide will be with furosemide, it is a loop diuretic. The potassium level will go down. So excess of potassium is also not good for heart, and low potassium will also cause heart issues like palpitation and dysarrhythmias. So we have to keep in mind, when the patient is on furosemide, the potassium level of the patient has to be monitored. If there is low potassium, we have to administer potassium supplements for the patient. Okay, and yeah, potassium tablets or potassium supplements has to be taken. But the problem with the potassium supplements, do you know what is the problem with the potassium supplements? Potassium tablets? There is an issue with the potassium tablets.
It causes irritation of the esophagus.
Yeah, it is so irritate, like it will irritate your esophagus. So the moment these are big tablets, and this big tablets, mostly it is sustained release tablets. You should not, if it is a sustained release or slow release, you should not crush those tablets. And these tablets, after taking those tablets, we have to drink plenty of water, at least 120 mils of water we have to take with a big glass of water. We have to take this potassium, and we have to tell the patient to sit straight for some time, at least for 30 minutes before the patient lie down, or because this will cause gastric irritation. And it is always good to have this particular potassium supplements with food. Okay, and there are some other drugs that will also cause total gastric irritation and esophagitis. Can you tell me any one drug which will cause esophagitis, just like potassium? And we have to again tell the patient to sit for 30 minutes with that drug. Which one? Which one?
Aldronate.
Dronades, right? Why we in which condition we are giving dronades?
Gout.
Arthritis.
Sorry, prevention of osteoarthritis.
Osteoporosis, right? Osteoporosis condition. So osteoporosis dronades we are giving, and dronades have the same esophagitis that can cause esophagitis. Okay, so it can cause pill-induced esophagitis. So in case of dronades and potassium supplements, we have to tell the patient to take with a full glass of water, at least 120 ml, and the patient has to sit for 30 minutes. Direct question, quick question. Who will read it? Amanda, read it fast. Amanda, is she there? If Amanda is not answering, Navjot.
A client with chronic heart failure is being discharged home on the furosemide and sustained release potassium chloride tablets. Which instructions related to the potassium supplements should the nurse give to the clients? A diet rich in protein and vitamin D will help with absorption. If the tablet is too large to swallow, crush and mix it with appliance or pudding. Potassium tablet should be taken on an empty stomach. Take it with a full glass of water and stay sitting upright afterward.
Yes, it is
Option
potassium
4.
chloride tablets.
Fourth one.
Option four. It's a direct question, and we are selecting option 4.
4.
Okay. Yeah, it should not be taken on an empty stomach because it will cause gastric irritation, and it has nothing to do with protein rich and vitamin D food because that will not increase absorption or nothing like that. And any drug, if they have mentioned, even if you don't know what is that particular drug, if it is sustained release, if it is SR, they have mentioned in the question, the tablet should not be crushed. Okay. Okay. Next question. Vinci.
The nurse is administering medications to a client experiencing heart palpitations who is scheduled to receive a dose of furosemide. Based on the client's lab values, sodium 140 milliequivalents per dl, potassium 2 milliequivalents per dl, urea 25 mg per dl. What is the nurse's priority action? Calculate total urinary output, hold the furosemide, notify the healthcare provider, obtain 12 lead ECG. Lab values. Hold the furosemide. This potassium is less.
Hold furosemide, and she was about to give the medication, right? The nurse is administering medication to a client experiencing heart palpitations, who is scheduled to receive a dose of furosemide. The first she has to hold. Then what she can do after that?
Notify the healthcare.
Notify the doctor.
She can go for a 12 lead ECG, right? She can go for a 12 lead ECG because the when you notify the doctor, he will definitely ask for all this.
Yes,
So before that, you can do whatever interventions you can do, and quickly you will be informing the doctor. Okay. Okay. Next question. Yeah. So another category of drugs which we use is some of the anticholinergic drugs. This anticholinergic drugs which we mainly use in case of overactive bladder. What do you mean by an overactive bladder? Overactive bladder. Overaction. What is that? It can be an overactive bladder.
Sorry.
Any answer? Overactive bladder.
What
do you mean by that?
Stimulate the bladder.
Not to stimulate bladder. It is actually the bladder which is like suddenly we feel like passing urine. There is no control. Okay. Suppose if this is like one of the videos when I saw they were showing that if there is an ox on your bladder, if the ox is pushing, like there is no control. Like you'll be suddenly passing without any, like you don't have any control over your bladder. So in that situation, the patients will be given some anticholinergic drugs. Okay. So the one of the important anticholinergic drug which we use is oxybutynin. Okay. This is for overactive bladder. So this oxybutynin comes under the category of comes under the category of anticholinergic drugs. So we have already learned what is anticholinergic drugs. They are anti-secretion drugs actually. That means they will reduce all the secretions. So if the patient is taking a drug which comes under the category of anticholinergic, there will be less production of all secretions will be less. So there will be less production of saliva, less production of your saliva, your ear drops, like tears will be less. You will be having less urine. You will be having less gastric fluids. Everything will be dry if you're taking anticholinergic. Okay. So it was the patients with glaucoma, blurred vision, and dry eyes. They have to avoid anticholinergic, and the patients with benign prostatic hyperplasia, they cannot pee, so they have to avoid. If the patient is taking anticholinergic, they have to avoid anticholinergic. And they can't poop because already the secretions are very less. So they have to use stool softeners and plenty of fluids, and artificial saliva because the secretions, tears will be very less. So we have to instruct the patient to use artificial saliva and sugarless candy. If the patient is taking oxybutynin, all the secretions will be less. All the secretions, whatever secretions our body is producing, everything will be less. So urine will be less, gastric secretions will be less, saliva will be less, tears will be less, everything will be less. So, and in case of glaucoma patients, we should not give any anticholinergic, especially oxybutynin. What is the main adverse effect? Since it is coming under the category of anticholinergic, there will be urinary retention. So the bladder will be extended. The urine will be inside the bladder and it will be retained. So if the patient is not urinating, the patient is having an overactive bladder. Because of that, we are giving oxybutynin. As a side effect of that, if the patient is not urinating the whole day, that has to be reported to the healthcare provider. And oxybutynin is also having all the secretions are low, right? So so there is the chance of hypertension. So slow position changes with anticholinergic or oxybutynin. And avoid hypothermia. That means already the secretions are less. If there is too much exposure to sun, so there's a chance that the patient will go to dehydration and hypovolemic state. Okay. Question. Quick. Anyone can quickly read. I think Binsi will respond.
The
first.
nurse is providing.
Yeah. You can read.
The nurse
Binsi,
is
you read.
providing discharge.
Who is reading now?
Navjot.
Not Binsi. Okay, now Jyoti.
The nurse
Continue,
is providing
continue.
discharge instructions to a client receiving oxybutynin for a overactive bladder. Which client statement indicates that further teaching is required? I am looking forward to our summer vacation at the beach. I plan to eat more fruits and vegetables to prevent constipation. I should not drive until I know how this drug affects me. I will drink at least 6 to 8 glasses of water daily.
Option 1.
Option 1, I'm looking forward to our summer vacation at the beach because the patient is having oxybutynin. That is an anticholinergic. Secretions are already low. There will be less everything secretions. The fluid will be less. So it is not good to have in sun exposure. Okay. Next question. Next question. We have only 2 minutes.
The nurse is conducting teaching with an elderly patient newly prescribed terazosin. Which instructions should be included in the teaching plan? SATA. It is not necessary to avoid foods that contain grapefruit. Make sure to change position slowly while on this position. I will not take this medication with antacids. Do not take sildenafil while on this medication. If you forget a dose of this medication, take 2 pills as soon as you remember.
2, 3, 4.
Option 2. One is correct.
Terazosin and tamsulosin. Yeah.
Option
One is correct. Yes, we can mix it.
Option 2 correct.
2 correct.
Option 2 is correct because this can cause hypotension. So slow position change. Okay, third one.
Yes.
Why you're not? Why you're going for that option?
Antacid should not be mixed with any other medication.
Yeah, antacids are anti-mixing, right? So antacid should not be mixed with any other medication. Very good. Next one.
Option 4.
Right, ma'am. Correct.
Do not take sildenafil. Sildenafil will cause further vasodilation, smooth muscle relaxation. So it should not be taken. And what about the fifth option?
No.
No, ma'am.
That's a common distractor which you can see in NCLEX. If you forget a dose of this medication, take 2 pills. So that's absolutely no. Okay. Next question. Which are the expected side effects of oxybutynin? Select all that
Dry
apply.
eyes, dry mouth.
Hypokalemia.
2, 3, and 5. 2 and 3.
2 and 3, right? Because hypokalemia we never mentioned anywhere, right? I think 2 and 3, yeah. Dry eyes and dry mouth. These are the, okay, next is pyridium. So this, if the patient is having urinary tract infection, when we take the patient, when the patient comes to a hospital or to a doctor, they will be provided with this medication. This is pyridium, and this will actually reduce that burning sensation and the pain of that and the discomfort of the patient. But this is not an antibiotic. But the only problem, this is not an antibiotic, that we have to educate the patient. And also the secretions will turn bright orange red with this medication, especially all the body fluids. So underwear, clothing, bedding, and even if the patient is using a contact lens, the tears can turn into, eye secretions can turn into dark red color. So there is so the patient has to avoid using contact lens when the patient is on pyridium. So these are some of the NCLEX points which we have to discuss. The question is, the healthcare provider prescribes pyridium for a client with urinary tract infection. Which are the expected findings with this medication?
Urine discoloration.
Urine discoloration. So you have to keep that medication in mind and you'll get the answer. Okay. I think this is the last one, Bethanicol. Bethanicol is mainly used to treat the neurogenic bladder or over-distended bladder. This is mainly seen in patients with any brain issues or spinal cord injury. They don't have any idea how much their bladder is distended. Okay, so this is the drug of choice is Bethanicol for better bladder control, and this will also help to treat urinary retention. It works by stimulating cholinergic receptors, so lots of sweating and urinary urgency will be happening. If the patient is on Bethanicol, the patients will be having urinary urgency and lots of sweating will happen. So this is a kind of mechanism that will reduce the body fluid. Okay, and as about K-Exhalate, as we all know that K-Exhalate will help to exit the potassium from the body. And it is when the patient is before administering K-Exhalate, we have to make sure that patient is having a normal bowel pattern. Suppose if the patient is having any constipation for a few days, or for a few days if the patient is constipating, if the patient has undergone a surgery of any bowel surgeries, or if the patient is having any fecal impaction, like there is intussusception or any issue with the normal bowel movement, there is a chance that if we are administering K-Exhalate, this will lead to intestinal necrosis. So we have to always check the patient's bowel pattern before administering K-Exhalate. Okay. Yeah. That's a main thing which we will be keeping in mind with K-Exhalate. Okay. This is the last question. Okay, last question. Who is reading the last question?
The nurse prepares to administer a prescribed dose of sodium polystyrene sulfate to a client with hyperkalemia. Which action by the nurse is most important prior to administering the dose? Assessing the client's abdomen and reviewing the medical record for frequency of stools. Assisting the client onto a bedside condomy. Teaching the client the importance of the frequent assessment of potassium and sodium levels. Verifying that the client had a daily weight assessment.
Option 1.
Yeah, option 1, because the bowel pattern of the patient we have to check before administering K-Exhalate. Okay, so with that we are, let me check the answer. Okay, with that we are winding up today's renal disorders and renal medication. If you have any doubts, you feel free to send a message, or we'll be clarifying you that. Otherwise, we can wind up today's session and we'll see you next week. Any doubts?
Can you please show the answer of that SATA question shown just before the oxybutynon?
This one, right?
No, the other one, just before this one.
Yeah.
Okay, thank you.
Okay. Any other doubts?
No, thank
I
you.
can. Okay,
No, ma'am.
thank you
Good
so
night.
much. We'll see you next week.